Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next, I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Belen Arevalo. Dr. Arevalo is a rheumatologist at Mass General. She completed her internal medicine training at Mount Sinai St. Luke's Roosevelt in New York, which has been renamed to Morningside West. She also completed her fellowship training in rheumatology at the University of Chicago. Her clinical and research interests revolve around the field of vasculitis. This interest stems from seeing many patients with various vasculitides and her involvement in research projects on heart risks in different rheumatic conditions, including vasculitis. She joins us today to give a talk on Raynaud's phenomenon. So please join me in welcoming Dr. Arevalo.
Thank you, Amy, for the kind introduction. So I'm just going to share my screen. Okay, is it working good? Yeah. Okay, welcome everyone. So today we're going to discuss about the diagnosis and management of Raynaud's phenomenon, which is something that we see pretty often. I do not have any disclosures. So the objectives for today's talk, we're going to discuss about what is Raynaud's, the classification, the differential diagnosis, why we use near-fold capillaroscopy and what that means, and also treatment for it. First of all, I would like to start with the definition of Raynaud's phenomenon. So this is a deregulated constriction of small vessels that leads to color changes to white color, red, blue color, which is usually associated with swelling, numbness, and tingling, and most commonly involves fingers and toes, but also can involve other body sites. So, for example, can involve the nose, the ears, and the nipples. It's very important to know that usually Raynaud's spares the thumbs, and that can occur either in primary or secondary Raynaud's. So what is the mechanism of this? So there are different proposed mechanisms. The first, there is vascular hyperreactivity, which means that basically there is constriction of the very small blood vessels that is going to lead to the color changes. There is also an increase in sympathetic nervous system activity, which also contributes to the vasoconstriction. And then there is involvement of different substances, different mechanisms, including serotonin, thromboxane, endothelin-1, and which is very important to know because we will see in treatment why we use some of the medications that we actually prescribe for Raynaud's. So the clinical presentation is sometimes a triphasic color pattern. The first color will be a white color because there is blanching secondary to vasoconstriction, occlusion of the small vessels, followed by a bluish, purplish color that is secondary to deoxygenation of the sequestered blood following the vasoconstriction of the small vessels. And the last color change is a red color, which is basically after the ischemia. It's very important to know that not all of these color changes are necessary for the diagnosis. Actually, the requirement is just only 2 of these color changes are necessary for the diagnosis of Raynaud's. So as we can see here is a very well demarcated color changes in the fingertips of this patient. So the symptoms, patients can manifest, pain, numbness and tingling, and also impaired function. Now, what is the diagnosis and the classification of Raynaud's? Well, when a patient comes to us and says, yeah, I have color changes, and usually just one color change, we can think that it's maybe, possible that the patient has Raynaud's. But when we definitely see and say, this patient has Raynaud's, is when the patient has at least 2 color changes, as we mentioned before, and if the patient has repetitive episodes of these color changes and other symptoms such as the numbness, the tingling, the swelling. So what questions are very important in terms of screening purposes? So ask the patient, are your fingers sensitive to cold? Do they change color when they are exposed to cold temperatures? Do they turn white, blue, or both? And then if the patient responds yes to all of these questions, so it's very likely that the patient has Raynaud's. Now, it's very important also to ask another questions. If these attacks are symmetric, if there is absence of ulcers, gangrene, necrosis, if all of these questions are important because, as we will see later, this is going to allow us to differentiate between primary and secondary Raynaud's. So what are the questions that actually, help us diagnosing Raynaud's? As we mentioned before, asking for about the color changes, if they are sensitive to cold temperatures, if they have associated symptoms, but also it's very helpful to ask the patients if they have a picture of the color changes, because most of the time you won't see the color changes in the office visit. So actually taking a look at a picture is very helpful. And also asking if there is involvement of other body sites, because as we just said, there is not only involvement of the fingertips or the toes, but also the nose, the ears can get involved. And then it's helpful to ask if the patient has, what is the occupation? Because some patients actually use vibratory tools, and the vibratory tools can be a trigger of these color changes, not only the cold temperatures. And knowing the occupation of the patient is going to also help us differentiate between primary and secondary Raynaud's, what medications the patient are using. And then with all of this information, we can then classify Raynaud's in primary and secondary. So what is primary Raynaud's? Primary just means that there is these color changes and you do not suspect that there is an underlying disease or an underlying rheumatologic process. So the primary Raynaud's is usually reversible, and then is usually induced by cold exposure. And why patients have these primary Raynaud's is because there is an exaggeration of a normal response to temperature. What is secondary? Secondary means that there is an association with an underlying disease. And essentially, there is a hyperreactivity in the blood vessels. One of the most common rheumatologic conditions associated with Raynaud's phenomenon is scleroderma, but we also have another rheumatologic conditions that can be associated with this. It's very important also to include in your differential diagnosis any mimickers of Raynaud's phenomenon. So what is important to ask besides the questions that I already mentioned in the history, and what is also important to take into account in the physical exam? So in terms of the history, it's very important to ask if what medications they are using, if the patient has, any hair loss, any color changes, any skin tightening, any sores in the nose, any sores in the mouth, because all of those symptoms, signs are suggestive of an underlying rheumatologic process. Now, in terms of the physical exam, as rheumatologists, we will see, if the patient has any skin thickening, any skin tightening, and any other signs, suggestive of connective tissue disease. But also it's very important, the blood work. So I have included here this algorithm because I think it's very, it's easy to read. And then it's very important for primary care physicians, essentially. So if you have a patient that you suspect that may have secondary Raynaud's, ordering an ANA actually is going to be helpful. Because if you have a negative ANA and the patient doesn't really have anything else in the history or the physical exam, then you can say, yeah, this patient has primary Raynaud's, right? But on the other hand, if you have patients with more signs or symptoms suggestive of a connective tissue disease, and on top of that, you have a positive ANA, so then your concern for an underlying rheumatologic process increases. When we have patients with a positive ANA in this scenario, we also order more specific antibodies, as are highlighted here in red. So secondary Raynaud's is one of the most common features of scleroderma. Actually, 95% of the patients with scleroderma will have Raynaud's phenomenon. The presence of Raynaud's phenomenon scores 3 out of the 9 required points for the ACR-EULAR classification criteria for scleroderma. So there was a study actually taking a look at patients with Raynaud's phenomenon, and actually they studied those patients over the years, and they saw how many patients progressed to connective tissue disease and specifically scleroderma. So from those patients who were diagnosed with primary Raynaud's, they transitioned to connective tissue disease 2.65 per 100 patient years, and specifically to scleroderma was 0.93. While those patients that were diagnosed with secondary Raynaud's, they transitioned to connective tissue disease 11 per 100 patients years, and specifically to scleroderma was 7.10. The patients who were at higher risk of progressing to connective tissue disease or scleroderma were those patients who have a positive ANA and an abnormal nail fold capillaroscopy that we'll discuss a little bit more into detail in the next slides. And then, what is the recommendation? So patients who have Raynaud's and who have a specific scleroderma antibodies, but they don't really have anything else so that you can call a scleroderma, or they don't meet enough criteria to diagnose with a specific rheumatologic process, we call these patients undifferentiated connective tissue disease. So in these patients, they saw that 32% evolved to scleroderma and 49% evolved into another connective tissue disease. That's why monitoring is very important in this subset of patients. This is the same that I have mentioned in the previous slide. So what are other causes of secondary Raynaud's? Well, another autoimmune diseases besides scleroderma, we talk about drugs such as beta blockers. We have also exposure to amphetamines are a trigger also for the color changes in fingertips. The occupation, we mentioned that is very important. When patients use these vibratory tools, we call this hand-arm vibration syndrome, because patients do have the same color changes, but they don't have anything else going on. And then also exclude large vessel disease. So what are the most common mimickers? The most common mimickers is embolism, atherosclerosis, is malignancies, hyperviscosity syndromes, because that also can cause the color changes, but it's not actually, secondary Raynaud's. What are the aggravating factors besides cold exposure? Is also emotional stress. So this is more common in patients with primary Raynaud's versus those with secondary Raynaud's. Smoking, atherosclerosis, carpal tunnel syndrome, all of them are aggravating factors for Raynaud's. So what is the physical exam? As we can see here, we have a picture with a fingertip ulcer. We have sclerodactyly that is associated with the skin tightening in the fingers. And this is the nail fold capillaroscopy that we'll discuss. So nail fold capillaroscopy is basically a tool that helps us seeing the very small vessels in the nail fold to see if there is any abnormalities that could be associated with an underlying rheumatologic process. So now the gold standard is actually video capillaroscope that combines a microscope with a digital video camera. But then not all the clinics have access to this video capillaroscope. So we can use actually a dermatoscope that is easier to use than an ophthalmoscope. There are also smartphones that can be adapted to a dermatoscope. However, the specificity is good, but the sensitivity is not that good, which means that if you don't see anything, it not necessarily indicates that the patient doesn't have any abnormality in the capillaroscopy. It just is not a good test when you use a smartphone. So in this table, we compare basically the cost and what is the reliability. So as we can see, dermatoscope, the cost is low to medium, and the reliability is as good as the video fluoroscopy. So you can start with that. So here, the picture to your left is they are pictures obtained with a dermatoscope, and the pictures on your right are obtained with a video capillaroscope. As you can see, the definition is much better with the video camera, right? So what are the features that we take into account when we're doing this nail fold capillaroscopy? It's basically the density of the capillaries, because when we see 7 or more, that is defined as normal. We also take a look at the dimension of the capillaries. When they are more than 50 micrometers, we call that giant capillaries, which is a feature in patients with scleroderma. We also take a look at the morphology, tortuous, crossing shape morphologies. Usually the most common morphology is like a hairpin. That is a normal morphology of the capillaries, and then the presence of hemorrhage. Now, the absence or presence of hemorrhage is not specific, because as you can see here, you will see in the future pictures that even patients with late scleroderma, they don't have hemorrhages. So that is not necessarily for a diagnosis. So you can see here is basically the capillary density. So we see here that we have in maybe per millimeter here, we have 4 capillaries, and we say that normal is 7 or more. So that will be a normal feature. The dimension, when it's more than 50, we call giant capillaries, as is indicated here by the arrow. So that is also normal. The morphology, hairpin, tortuous is normal, but all other morphologies are considered abnormal, as we can see here. And in the last row, we can see the presence of hemorrhages. So I really like this table, because this table basically summarizes what we see in terms of the nail fold capillaroscopy in patients with early, active, and late stage scleroderma. As we can see here, that is highlighted by the yellow arrow, patients with early scleroderma, the nail fold capillaroscopy is pretty much normal. So that's why ordering further blood work in those patients, such as having an ANA or any other scleroderma-specific antibody, will be helpful in terms of monitoring for complications. So here in early scleroderma, you may see giant capillaries, but you are not going to see any other abnormal feature. While in patients with active scleroderma, you will have lower density, you will have giant capillaries and a normal morphology, and you can have hemorrhages. And in late stage scleroderma, the density of the capillaries decreases further, and then you are not going to really see hemorrhages, and you're not going to see giant capillaries. So we were talking about ANA, right? To see if the patient has an underlying rheumatologic condition. So now, what if the ANA comes back negative? That is it, or you should pursue further? Well, probably this is one of the few cases that we really take a look at the stain. If there is a cytoplasmic stain, even though the ANA is negative, that may be a feature that is, indicating you that there may be antibodies, such as antisynthetase antibodies. So antisynthetase syndrome is autoimmune disease that involves the muscle, the lungs, the joints, etc. And one of the main features is also Raynaud's phenomenon. And those patients usually have a negative ANA, but the stain will be cytoplasmic. So that is an indication to pursue further workup. As we mentioned before, when we have patients with Raynaud's, a positive ANA, but they don't really have anything else, to classify them as having a specific rheumatologic condition, we call them undifferentiated connective tissue disease. So up to 56% of these patients will have Raynaud's phenomenon. There is a study that showed that if you monitor them for 5 years, most of the patients will evolve into an overt connective tissue disease within the first 3 to 5 years. And then one of the most important predictors of this evolution was having an abnormal nail fold capillaroscopy or progression of the nail fold capillaroscopy. Now, some examples. So here we have basically, the density of the capillaries. We discussed that 7 or more is normal. Here we can see roughly 5 capillaries in 1 millimeter, which is considered as a normal. Here also we see some giant capillaries, which is anormal. In the picture to your left, we see also giant capillaries. We see some hemorrhages as well. In the picture to your right, you see some hemorrhages there. So basically what we see in patients with scleroderma? So here you can see in the first picture, we have giant capillaries. We have the presence of some hemorrhages. Then in the second picture, you will have also giant capillaries, and we see an abnormal morphology. And in the last picture, you see literally maybe 1 or 2 capillaries, and then you have an abnormal morphology, but you don't really see any hemorrhages as we expect, right? We say that in patients with late stage scleroderma, you don't really see hemorrhages, and hemorrhages is not a specific finding anyways. So in terms of differential diagnosis, why is very important when we were like, when I was mentioning what questions we should ask our patients when they come and say that have these color changes when they are exposed to cold temperatures. One of the questions that is very important is to see if the color change is actually demarcated, or if they can show you a picture. Why? Because we have different color changes that can involve the hands and feet, but not necessarily is Raynaud's. So sometimes I have patients that get referred to rheumatology because of Raynaud's, but actually they don't have Raynaud's. They have, for example, ectrocyanosis or pernio. So what is the difference between them? So primary Raynaud's is an episodic color change, right? Pernio can be also episodic as well as levator reticularis, but in primary ectrocyanosis, literally you have a persistent color change that is mainly involving hands and feet, while in Raynaud's is well demarcated. In Pernio is not that well demarcated and is not only involvement of the fingertips, is involvement of the finger pads, the toe pads, and even the dorsum of the hands. Now, what is levator reticularis? It's a net-like color change that usually involves just the lower extremity. So as you can see, we have different conditions that can cause color changes in the extremities, but knowing if they are episodic, if they have a well-defined demarcation, what color changes do they change to, all of that help us differentiate it between Raynaud's and all of these disorders that are stated in this table. So what is the treatment? So in some clinical trials that are used, in patients with scleroderma, so the endpoint for Raynaud's phenomenon is called the Raynaud's condition score. That basically quantifies the frequency of Raynaud's, the duration, and the severity over 1 to 2 weeks. We always start with conservative measures, even in patients with secondary Raynaud's that is associated with a connective tissue disease or rheumatologic condition. So the conservative measures that are very important is basically avoidance of cold temperatures, dressing warmly. It's very important to keep the core body warm because sometimes patients come with, hand warmers, etc., but actually the core body is cold. So if you don't have the core body warm, you still are gonna develop color changes in the fingertips or toes. Stop smoking is very important because smoking promotes vasoconstriction. So what about medications? Well, when the frequency of attacks increases, when the patients mention that they are having some ulcers in the fingertips, well, then is when we actually start medication. The first line is a calcium channel blocker. That is the same medication that primary care physicians use to treat high blood pressure, hypertension. So it's a pretty benign medication, and the goal of this medication is to open up the blood vessels. Now, it's more effective in primary than in secondary Raynaud's. If we titrate the dose up of the calcium channel blocker, the most commonly used ones are amlodipine and nifedipine. If the patient doesn't really respond to that, so then the next step is adding a second medication. And what is this second medication? Is sildenafil. And the mechanism of action is a phosphodiesterase 5 inhibitor that has kind of the same mechanism of action that a calcium channel blocker, opening up the blood vessels so that there is more blood flow to the fingertips and toes. Now, when we talk about mechanisms, I say that all of those mechanisms are important when it comes to management options. Why? Because we say that serotonin can be a mechanism, right, in Raynaud's phenomenon. And that's why in some patients we use fluoxetine, because fluoxetine also have shown to have, the same mechanism of a calcium channel blocker in terms of opening up the blood vessel, but doesn't necessarily cause the vasodilatory side effects that you can see with other drugs, causing headaches, pre-syncope, of aggravation of acid reflux in scleroderma patients in specific. So we can use that. Sometimes we use ACE inhibitors, ARF, which are also medications used to treat high blood pressure. And then there is no good evidence about the use of antiplatelets, but some studies have shown that actually these patients with scleroderma can have an activation and platelet aggregation. So if you add aspirin in that patient who has like increased frequency of Raynaud's phenomenon, they are severe, they are associated with numbness, tingling, and it's pretty symptomatic. So you can add actually aspirin. Now, how about complicated Raynaud's? So complicated Raynaud's, we call it when there is a progression to digital ulceration or ischemia. So here is very important to exclude any concomitant pathology. So in these patients are the ones that we're gonna order imaging because we wanna make sure that there is not any blood vessel occlusion. It's very important in these patients to have combination therapy. So if that patient was on calcium channel blocker, so it will be worth adding a second medication such as sildenafil, which is a phosphodiesterase 5 inhibitor. And then in the patients that do not respond to those initial measures, so sometimes we need actually to start them on IV therapy. And usually we use the prostanoid. So in Europe, they use a different medication that is approved there for severe complicated Raynaud's phenomenon, which is iloprost. Something that I would like to emphasize is about pain control. Why? Because actually pain can exacerbate the vasoconstriction, the vasospasm. So there are different things that we do in patients with complicated Raynaud's that comes with ulcers. So besides, up titrating the dose of the medication or adding a second line agent, adding aspirin, it's very important to know if there is also infection, because when there is ischemia, there is also associated infection, so antibiotics are important, and pain control. Again, why? Because can exacerbate the vasoconstriction and makes the Raynaud's phenomenon worse. So as important as it is, after treating a calcium channel blocker, is also very important prescribing something for analgesia. So there is an algorithm that summarizes what I have mentioned. If you have a patient with primary mild Raynaud's that is usually defined less than 5 attacks per week, you can start with conservative measures, and then you can monitor the patient, and you will see maybe some patients only need a calcium channel blocker during the winter months, and that is it. And then, but how about the patient who comes with an increased frequency of Raynaud's phenomenon, perhaps that patient that has ulcers, Raynaud's, so that is an indication to start medication. And as we discussed, the first line therapy will be a calcium channel blocker. So how about surgery? Before, like several years ago, like sympathectomy was recommended, cervical sympathectomy, but is no longer recommended. And then sometimes botulinum toxin injection can be done, but there is little evidence supporting its benefit. In terms of prevention of attacks, we discussed stop smoking. We discussed, being mindful about the other medications that the patient is using. Now, I discussed about beta blockers, but it's important to know that not all the beta blockers are contraindicated in Raynaud's phenomenon. For example, labetalol is safe to use. Those are the references that I have used in my presentation. I hope this was useful to you, and then I'm open for any questions. Thank you.
Thank you so much. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding whether the length of time one has primary Raynaud's whether or not it's linked to the likelihood of developing secondary Raynaud's.
Okay, that's very important. So not really. No, the length is not associated with whether the patient has primary or secondary. That is not a feature that, will raise a suspicion for an underlying connective tissue disease. And I also see here that why 13 fingers or toes in primary. So that is not only primary Raynaud's, also in secondary Raynaud's, usually the thumbs get spared. So that's for both types of Raynaud's.
Thank you. And if someone suspects or concerned about whether or not they have Raynaud's, what would be the first step be? Should they have discussion with their primary care doctor or go see a specialist?
Yeah, so that's a good question. So usually they can discuss with the primary care doctor. So the primary care doctor usually, based on the history and the physical exam findings, also they have a suspicion for a rheumatologic process and they will refer those patients to rheumatology. Not every single patient with Raynaud's have to see rheumatology because as we saw, like there are different conditions that can cause the color changes and it's not necessarily Raynaud's. And even if it is Raynaud's, it's not necessarily secondary to a rheumatologic process. So I think having, initial visit with a primary care physician who can identify another, concerning signs or symptoms will be the right way to go.
Thank you. And I know you had discussed this earlier on. I don't know if you have any additional thoughts you'd like to share about regarding medications. Are they generally during certain episodes or something that they'll have to be on for long term?
So in terms of medications, so if the patient fails the conservative measures, then yeah, we start medications. How we do it is actually depends on the patient. Sometimes patients need to be on that long term because even during the summer, the air conditioner, because it's cold, can induce the color changes. So even during summer, some patients may need it. Other patients are like only need during the winter months. And then in terms of dosing of the medications, so it's a little bit maybe higher than the dose that we use in patients to treat high blood pressure. And then one thing that we recommend when patients are on different medications, let's say 2 medications for the Raynaud's, we always recommend monitoring the blood pressure because the mechanism of action of all of this is basically open up the blood vessels and the side effect is going to be, low blood pressure. So it's very important for the patient to monitor the blood pressure when they are on 2 or more medications for Raynaud's.
Thank you. And what are the most common causes of onset of adult primary Raynaud's?
So it's actually just induced by cold temperatures. So that is the most common cause. But honestly, I can tell you, like the patients that I see, all of them have different triggers. Some of them will have like, they are taking cold medications. Other ones will be related to the occupation or just having primary Raynaud's, but nothing else going on.
Thank you. Do you have any recommendations on what other preventive measures could be taken aside from warm clothing, hand, feet warmers to prevent any episodes when you know you'll be in a colder setting, such as going for a winter hike?
Yeah, avoiding any other drug that can exacerbate the symptoms. But honestly, all of the conservative measures that I mentioned there, those are the ones that we use. We really recommend hand and feet warmers. And despite having, not taking any other extra medication that may exacerbate the episode, and you are having a good conservative measures, and still you're having like an increased frequency of Raynaud's, so maybe you will be a good candidate to start medication for Raynaud's.
Thank you. We have an audience member whose grandmother had Crest syndrome with Raynaud's. Do you know if this is hereditary? Should they get tested for it?
So that's a good question. So usually patients who have, one of the main questions that we always ask in the initial visit to our patients is if they have family members with an autoimmune disease. That doesn't mean that you necessarily are going to have Crest in the future, but if you're having like any signs or symptoms, such as yourself, you're having Raynaud's and you're having hair loss, for example, you feel like your skin is getting tighter or things like that, so maybe you will be the right patient to have an screening ANA test but it's not something that we do in everyone, you know, even if the patient has a family history for autoimmune disease.
Thank you. We have a question regarding medications. What types of medications can worsen Raynaud's?
The medications that increases the activity in the sympathetic nervous system, so meaning, for example, beta blockers. I mentioned labetalol is a beta blocker that is safe to use. The over-the-counter medications used, you know, to treat a regular cold, also those medications may exacerbate Raynaud's.
And are there any exercises or massage therapies that could be helpful for patients with Raynaud's?
Not really, no.
Thank you. So why don't we give it another minute to see if there are any additional questions in the chat? Otherwise, I think it'd be fine to end early. While we wait to see if there are any additional questions, are there any final thoughts you'd like to share with the audience?
Yeah, that, you know, it's very important to monitor. Something that I always recommend to my patients is to monitor the frequency. Like, let's say this winter I had like maybe one episode per week. Maybe next winter I'm having 2 to 3. That is kind of unusual for me. So that will be nice to follow up with your PCP if that is the case, because maybe you will be, as I say, the right candidate to start medication. And what is the main goal of starting medication? Preventing ulcers, preventing gangrene. So that is basically the main goal of, as physicians, as rheumatologists, you know, when we put a patient on a medication, it's basically to prevent ulcers or to prevent complications from Raynaud's.
Thank you. We have a question regarding scheduling an appointment. How can patients schedule an appointment to be evaluated?
So the PCP can refer you to rheumatology, and then, you know, depending on availability, you will get a schedule with a rheumatologist.
Perfect. Thank you so much. I don't think we have any further questions in the chat, so I think we can end a few minutes early. Thank you so much for spending the hour with us. Greatly appreciate this. It was extremely helpful. And as I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone.
Thank you. Bye.